Our next presentation, Can Ethics Help?, will provide a look at the overall purpose of immunization for individuals and the impact on others. This presentation will highlight the values, beliefs, tension that may be encountered when immunizing and describe an ethics framework to assist when confronted with ethical issues such as patients' requests for designer immunization schedules and challenges regarding conflicted consent for childhood immunization. Our final distinguished presenter this morning is Dr. Eric Wasylenko. Eric Wasylenko is a palliative care physician and a clinical ethicist. He began his career as a rural family physician. Currently, Eric consults to the Health Quality Council of Alberta, Alberta Health Services, and Alberta Health. He assists in the development of provincial pandemic planning, especially related to ethical issues. Eric is a member of the Alberta Advisory Committee on Immunization and is chair of the Public Health Ethics Consultative Group for the Public Health Agency of Canada. Please join me in welcoming Dr. Eric Wasylenko.
Thanks very much, Pamela, and good morning. Thanks for having me here today. As I was walking in, one of my colleagues said, "Oh, I'm glad you're here. You're going to tell us what to do." And she doesn't know that my household is comprised of myself, my wife, my 4 daughters, my 2 stepdaughters, and a female dog. So I can say whatever I want. No, it's actually very refreshing that I was asked that, because no one asked me that at home, what to do. But even if I decide to tell people what to do, it doesn't matter because no one listens. So it is nice to get a word in edgewise. So thanks. I got the podium for a few minutes, and I'll try to keep this to the right time frame. So presenter disclosure. No commercial interest to note, but since I have this bone to pick about conflict of interest, it's not just about money, it's also about conflict of commitment, and the multiple organizations we're all in, I think it's appropriate to let you know as well that I do collaborate on some other research grants, but not related, and I'm a consultant to a number of these organizations, and sometimes that does impact the issues that we have to deal with. So my outline is just, I'm going to talk a little bit about ethics in general, and I'm not going to tell you what to do about these tough issues. That's not really my role, and in 25 minutes I can't do that anyway. Public health ethics and frameworks I'll talk a little bit about, and then I'm going to apply it just to a few of the issues that we deal with: vaccine hesitancy, designer schedules, and conflicted consent. So I'm going to ask you, if you don't mind, because we have to do a bit of audience participation, we heard. Tell me how many of you have access directly to ethics consultative services in the front line. So a few of you do, which is great, and I bet a number of you are from Calgary, because we know we've got that capacity in Calgary. Not a lot of people actually in public health ethics or public health and immunization clinics have access to that. So some of these particular questions we see at the front line all the time. And in the end, I'm going to talk just a little bit about some issues around moral distress and the impact on our health providers. And many of you in the room are frontline health providers. Many of you are managers, program leaders, developers, etc. And you do face these kind of tough issues. So I'm going to talk a little bit about ethics as well. Many of you have training in your professional disciplines around ethics. I'm going to try to frame it in a slightly different way. Ethics is a branch of philosophy that deals with human behavior in the context of a society, and that's a really important issue because we all learn about the individually focused approach that bioethics has engendered in our North American society for the last 40 or 50 years, and it is very individually focused. It's not community focused, and this definition is really important because we do not exist as islands. We exist in community as part of society, and that really has an impact on the way that we encapsulate the principles or the values around ethics thought in what we do. It also is how we decide and justify what constitutes right and wrong behavior, as well as just and unjust decisions. Sometimes we have to decide amongst multiple valid choices. So you have two things that are, seem like really good things to do. One may be more expensive than another, or for some reason you can't do both. You have to decide between them, and that's often what ethics issues are about. Sometimes we must decide amongst a series of choices, none of which feel like they're very good. But we still have to do something moving forward, so we have to choose amongst those. And sometimes our choices are a bit more clear-cut. So this says, your child is being eaten by a camel. Do you save your child or take a photo? So what were they thinking? So what does ethics provide us with? It's a way of looking at the world and complex problems that exist within it and within our healthcare environment, certainly, so that we can do a number of things. We can identify options for decisions and behavior that we face. We can choose from amongst those options a course of action that's defensible, that is according to rational thought, and especially is according to community and individual values and beliefs and standards, and those have to be named. But what ethics is not is also important to say. So it's not a simple list of values and principles to pick from amongst. It's not formulaic decision trees. It's not policing. And it certainly is not moralizing or judging. There are several branches of ethics. There's research ethics that you're all aware of, clinical applied ethics, and that's what we're going to talk a little bit more about today, and organizational ethics, which really talks about how organizations deal with internal and external relationships and partners. Clinical applied ethics talks about on-the-ground things that we do and the way we might want to make decisions around conflicted issues. You've all heard about utility, utilitarianism, probably Kantianism, communitarianism. Those are examples of moral theories that help us address and resolve the tensions and the decisions around ethical troubling issues. And then there's, apart from the moral theories, the foundational approaches that we use to actually get at some of these issues. So, for example, we're all really familiar in North America, especially with principlism. So it talks about a series or a list of principles that we might turn to deal with issues. And there's another approach called feminist ethics, which really describes the way that we must attend to those who are most marginalized or vulnerable in the population, arising from the feminist movement of the 60s that said people equally ought to be able to have the benefits of all that society can offer and have equal opportunities. So in feminist ethics approaches, an example might be, we say if we have a limited supply of immunizations or vaccinations, we must make sure that we apply that limited supply to the people who are most vulnerable in society first. That would be an example. And then there's virtue ethics as well. And it's really important to note that not a single approach is helpful enough in the complex kinds of issues or decisions that we have to make in ethics thought. I will turn to principlism a bit because it's the most familiar to people. There are four primary principles usually talked about. Respect for autonomy, and it's not just autonomy itself, but respecting people's ability to choose for themselves and to develop and approach the aims that they have for themselves. Being beneficial in everything we do, not causing any harm in what we do, and being fair to all in treating like things in a like manner, like people in a like manner, and making sure things are allocated in a fair way. But there's lots of other principles that are named, and in pandemic work, for instance, we have a list of about 10 or 12 other principles that we would often turn to, like subsidiarity, least intrusiveness, things like talking up to people and making sure that we focus on the issues that people face who are closest to the ground of decision making. So it's important that we relatively weigh the principles. It's always situational. We cannot say that respect for autonomy always takes precedence over beneficence, or that non-maleficence always takes precedence over beneficence, as an example. It's always situational. But unfortunately, we have a tendency to cherry pick from the list. And so we will say, well, yeah, everybody agrees with justice, or everybody agrees with the notion of fairness, and this particular policy that we're going to develop is because we need to have fairness. And so, yeah, we're going to have to all believe in this particular policy because of it. And things are much more complex, of course, in our society, as you know. So what are we trying to do in an ethics analysis? First, and foremost, we have to identify an ethics question, and that's where we often fall down. We don't really clearly state what are we trying to get at in an ethics analysis. Then we must hear from multiple perspectives and all players. So it is not about somebody getting up and saying, well, here's what the right thing is to do. It's about actually having people get together or come together and sort out and explain what their values and beliefs and principles are, hearing from each of those sides, and then also analyzing the issue and possible resolutions using a fundamental framework or a disciplined approach, of which there are many. You have to also consider mitigation strategies that will alter the impact of each of the factors that are situational in the issue. So there might be particular program elements that you can invoke, or you can involve different players that will fundamentally change the situation that you're facing, and those are parts of ethics deliberation. And then you need to choose a course of action that's ethically defensible and appears to be the best course, all things considered. And usually we're not left with saying, oh, this is really obvious. If it was that obvious, it probably wouldn't have required an ethics focus in the first place. So you have to make sure that you've considered all the relevant factors, that you've done a really disciplined job of thinking what you might have missed out, and then come up with a defensible course of action and evaluate it, all those sorts of things. So here's the defensible action. Depends on kind of who you're asking what might be the right approach to take. So I'm not sure we want to ask the guy on the bottom what he's preferring happens. So there's a primary tension that usually exists now between individually focused interests, health, and care goals, and community-focused health, well-being, and interests. And that's the fundamental problem with public health ethics. We've grown up so familiar with this notion of, we in our North American society, we think we're wealthy, we can manage things for ourselves, we don't need anybody else to tell us what to do, we're not facing survival every moment of every day, or at least most of us aren't. We think that this individually focused notion of you can't tell us as the government or as an agency, public health or otherwise, what we can do. Don't tell me that I should drink water that has chemicals like fluoride in it. Don't tell me that I must put my seatbelt on. Don't tell me that I can't smoke in a car with my children. Those sorts of things. We really believe in our society that individually focused or autonomous choices are the be-all and end-all. And each of you have thought those things, I can assure you, I certainly have, in the context of our daily lives. But in public health, it's very different, because we have to also recognize that while personal respect for freedom and personal autonomous decision-making is vitally important in our society, we do exist as part of a society. So how do those individually focused decisions and rights and freedoms, all those things that we cherish, actually impact our living as a group of community, somebody in a group of community members? So what might be core ethics considerations in public health? So there's lots of ways to frame this, and work's underway to establish a common set of considerations. We're doing that work through the Public Health Agency of Canada. And here's an example of a set. Now, this isn't exactly what we're doing at PHAC, but it approximates it. So here's just three sort of ways you can look at public health ethics. So we have to first be fair to individuals and communities, and that includes a whole bunch of groups. So citizens, patients or clients, providers and leaders, specific sub-communities of people, and then the entire communities of people. We need to be fair to all of those groups, and that's where it becomes really complex. We secondly need to trust in others, and that's reflected in the ways of being that we have with each other, the ways we act. Institutional commitments we have to people. So what is government saying we're committed to? What is the public health agency committing to? What is this group of vaccinators in a public health clinic committing to for the population? And then stewardship, which talks about being really carefully attending to our responsibilities to utilize our resources in a most effective and efficient way, because we actually do husband those resources, and we have to make sure that we're applying them in a really effective way for the multitude of things that people expect us to do. And then there's this notion of solidarity and reciprocity. We saw that in pandemic really clearly. So how do you make sure you exist and don't take things for yourselves that others need as well. One of my issues with some of the statements that each of you in your jurisdictions have heard from either yourselves or from your governments or others saying we need to be the best. Well, if we need to be the best, that means somebody else isn't the best. So if the group in Manitoba says they're the best at something and they need to be, and that's their measuring stick, that's automatically saying that somebody in Saskatchewan is not going to be the best or the program's not going to be the best. Is that what we really want to foster as a notion? And when we talk about solidarity and reciprocity, we talk really carefully about the need to actually do what we can for ourselves and others as well. And then there's this notion of good process. So we need to be inclusive of all those people, as an example, who have a part to play or some status in the particular decision and who will be impacted by the decision. And then finally, the third notion would be respect. And we respect the inherent worth of persons and the inherent worth of communities, and how those people actually name their own communities. Both for, we have to respect individual and group rights, we have to respect decisional autonomy of individuals and those groups to make their own decisions, and then again respect the importance of good process. So let's talk about a few of these issues, and of course, in this short space of time, not going to go into real depth about the ethics of each of them, but these are particular things that our frontline immunizers and managers have asked us to help them with because they face moral distress around them. So here's the tensions around vaccine hesitancy. We want to respect the choices of parents and the guardians of children. That's just the way we are in society. We also recognize, though, that there are parental, societal, and professional duties to children, and we each have those duties to children, both in the large sphere when we're managing programs, but also individually. So if you are a nurse and there is a child and a parent before you, that child and that parent are your duty and your responsibility. Same for a physician, same for a pharmacist. We need to make sure that we understand the duty to assure accurate information and not biased information. So according to our own sort of prescription of what we think is the right thing to do. We make sure that we're efficient in the distribution and the application of our resources. So it is vitally important if I'm a public health nurse and I'm immunizing a child, and it's also my role to make sure that I've done a little bit of a well baby check at the same time, even though I'm kind of monitoring to see this vulnerable woman who's in front of me and her child, who maybe lives on the street, that I've tried to manage all the other things around her life and help understand where some risks are. It's my duty to identify those things. Yet I also have a duty to make sure that I don't spend more than my 20 minutes or whatever you get with her, because there's a whole bunch of other people waiting in line to see me as well. How do we manage that tension? And then there's risks, of course, to others from not being immunized. How do I honor this person's ability, this parent's ability to decide for herself or for himself and their child's sake, yet also worry about all those other people that I have a duty to perform for. So I need to do my job to make sure I try to convince this person because there's a risk for the rest of the community. And then, of course, there's this tension about the direct societal costs of illness care. So can I justify as a program manager or as a government, say I'm not really going to worry about Dr. Jadavi's 6% that he talked about. It's not a really high number because there is actually a direct societal cost of illness care for those people who will more likely get sick because they're not immunized. And there is also, of course, a direct cost to that particular child and family. So how might we frame the ethics question? And that's really key. I'm going to do that with each of these three issues. So here's one way that I would frame the question, and it is the question that really matters. So in ethics consults, we often help the people who are asking for some assistance or some guidance around this. What is your ethics question? Don't just describe the situation, but give me an ethics question. If you can't, then we'll help frame that and see if this seems to resonate or make sense. So I might ask, how much resource ought we put into educating or convincing vaccine-hesitant parents? So if I'm Dr. Jadavi and Dr. Kellner and I'm thinking about that from a system level, there's a certain kind of answer that I might give. If I'm thinking about it as the manager of 60 staff who are vaccinating in the next few months in an influenza campaign, I might think about that differently. And if I'm a frontline staff worker actually doing that vaccination, and I'm facing the challenge of trying to get the throughput that I need to in my day because there's a lot of other people who I need to vaccinate, I might think of that in a completely different way. So asking the question in this way is really important. There are other ways to frame the questions, and there's a multitude, of course, in vaccine hesitancy. So the next issue might be designer schedules. So you've seen this lots. Either a physician recommends to a parent, or a parent comes in and says, well, I really believe that I want the mumps vaccination, but I don't want the rubella vaccination. And you've said that you're going to honor in some way or respect my ability to make those determinations or decisions. And I know that I might not know, I probably don't know that it's a lot of extra work for you to actually create that second kind of immunization, which you may not even have available. What's the tension? So again, it's the same things. We're respecting the choices of parents and guardians, the duties to the children, the duty to ensure accurate information about this, the efficiency of the distribution application, the risk to others from non-immunity and direct societal cost of illness care. So the same kinds of tensions exist in that difficult ethics question. But how might we frame that one? So here's two examples. Should parents be allowed to direct their children's own vaccination schedule? So that's a pretty straightforward question that has an exploratory sort of ethics answer. Or who ought to take precedence for vaccination appointment access? Children on standard schedules or children with designer schedules? Very different way of asking the question, isn't it? So when we know we're behind, and we talked all this morning, and we will the rest of the next 2 days, about this notion of trying to convince the population, parents certainly, but the population in general, of the value and the need to stick to an immunization schedule, because it does matter. And it's also efficient and effective for us to keep people sticking to a schedule. But we're behind because we don't have enough resources. And is it that when we're behind, we should think about this particular question and say, so I've got two parents, one parent who says, I want a designer schedule for my kid, and another parent who is saying, why can't you get me in for my 4-month shot on time? It's 3 weeks or 6 weeks and sometimes several months late. Who am I supposed to take care of first? And in my sort of frustrated, angry voice, I might say, I'm going to take care of the person who's buying our program. But is that really advocating appropriately for the other child who might need, in fact, your services more than the first child? And then the issue of conflicted consent. So there's a tension about all these 6 things that I've listed for the others, but there's an additional issue. So we have a duty as healthcare workers and as society members not to increase the risk of harm or familial conflict. And so in that great example that Dr. Jadavi gave regarding the one parent who was actually probably looking for the opportunity to speak with him in his office about the notion of right education and is there a way that I can think about this problem more? And the other parent who said absolutely no, and this is a really nice story that he gave because it was a happy outcome, good education and a beautiful approach that he made with the parents, and using the leverage points that he had actually convinced the mother. That's not always the case, and that's not always the case that it happens. So we don't want to increase that risk of familial conflict, and in many especially immigrant cultures, but not only immigrant cultures, we see that those tensions and conflicts between spouses or members of a family can be really serious and have serious consequences for the children and for each other. We need to make sure we're not increasing that familial conflict. How to do that is a challenge. We need to be fair to all parties, but we have uncertainty around the respect for autonomy, and we have to ask the question, whose autonomy? So who do we get to favor or advantage? We want to favor or advantage the person who's kind of on our side, but that's not necessarily what we need to do. We need to be least intrusive as possible so that we're, again, not impacting this family in a really negative way. That sounds nice. It's easy to say. It's very hard to do in public circumstances. So how might we frame the ethics question around conflicted consent? It could be these. Under what circumstances ought staff get involved to resolve parental disagreement regarding a child's vaccinations? So if I'm a physician in my family practice And I feel like I've got the ability to, I've had some connection with this family. They respect me in some degree, and I'm confident in my ability to say what my duty to fulfill, to say what I think I need to say. That might be very different than a nurse in the frontline clinic who is facing the resource constraint of getting people through and wondering if it's actually his or her duty to get involved in this disagreement. Certainly a lot easier to let it go. Or we could ask, ought staff decide between conflicted parental decisions? Is it even our duty in the health system to do so? Or we could ask, should our policy require double parental consent, subject, of course, to guardianship status? So in today's environment, where there are many people who come from families that are reconstituted, it would be really important, and that's not freeze-dried first, it would be really important that this notion of parental consent be thought about really carefully. So those are three different ways, and what I'm trying to get at is the way you ask the question really influences the way you get at the answer as well. So a couple of other things to point out before I conclude. There's this thing that we like a lot in ethics discourse called risk matrix, and you use this all the time in your everyday decision making. So what's the likelihood of an event occurring, and what's the degree of impact, positive or negative, if the event occurs? All right, that's the way we make most of our decisions in our daily lives. So if I'm speeding down the road and it's icy, what's the likelihood of an event occurring? It's probably reasonably high. And the degree of impact, if I have an accident or a traffic crash, it's not an accident, would be very negative if that event occurred. So on that risk matrix, in a 4-quadrant risk diagram, that would be a really silly decision. There's lots of things we do. The likelihood of an event occurring is high, but the impact is not very bad. So we might take those particular choices in our daily lives. That platform helps assign relative weight to each of the considerations we make in our decisions when we're balancing them from amongst competing values. So, for instance, the degree of harm impacts our duties to protect. If there is a great degree of harm, we have a higher duty in the health system to make sure we protect people from that harm, both by policies and by the actual interactions we have in the healthcare environment. If there is certainty of evidence or uncertainty of evidence, it may impact the degree of flexibility allowed. So if we really don't know that the rotavirus vaccination makes a difference, it's going to really impact the direction or the aggressiveness with which we decide as a program that we're going to include this at a high cost, or if you're a frontline worker, the degree to which you're going to push this with the clients that you're taking care of. If we have great evidence that it makes, excuse me, great evidence that it makes a lot of difference, then that will impact our proscriptive sort of action to say, no, there isn't a lot of flexibility allowed. This does make a difference. We must have it as part of our program. And then there's process considerations. So we need consistent and transparent processes for these predictable scenarios that I've outlined. You all have faced them. We need to get at them, actually, and decide what to do. But I'm going to argue that we have done probably a fairly poor job of including clients and the public in the policy and procedure development. Community wisdom is necessary about this. We don't have it. We don't know well enough from individuals, and certainly from community or social sciences, the kinds of things that impact decision making for our clients and for the population. So we don't know that information very well. We have great ideas about how to influence this, but we need to access that community wisdom in a much more wholesome way. And an ethics language sort of rule would say that we must include those people who are most impacted by our policies and by what we offer and the resources we applied. We just haven't done that very well. We need to support public accountability and inclusiveness. We need to help address staff and manager moral distress. And I'll get to that in a minute. I just wanted to highlight an example. I was reading in the Herald last night a great story, and some of you may have seen this, about a researcher, I can't even remember if it was Alberta or from Ontario, who has recognized that there's this neat thing that when my kids were really small I didn't know anything about, and it's actually a sound modulator that filters out white noise so kids can go to sleep. And so, you know, my arm's longer because I did so much rocking when I was a young dad, but those would have been pretty cool things to have. And I guess there's parties that go, I'm just now at the age as long in medicine as Dr. Jadavi, and I started earlier than you did, though I was only 10. So I'm at the age where some of my nephews and nieces are now having kids. So, and I'm just sort of really out of touch about the kinds of things that young parents are passing back and forth. So apparently there's these parties where people actually either give or pass along their sound attenuator to the next parent. So kids can fall asleep apparently more easily because they've got the sound attenuation near them. So this researcher was recognizing, or it was a clinician as well, recognizing that there's a problem with this and measured the decibel level. So within inches of the kid's head, sort of on the crib slats, the decibel was like 85 decibels, constantly on this child's ears. What does that do to kids' hearing development? We don't know what it does, but we can imagine what it does. So, you know, good parents thinking well about both their own health and sleep, as well as trying to have their child have a normal, natural sleep. We do really bad things to people, well-intentioned and well-meaning, right? So the issue for me around this is that we don't really understand well enough the kinds of things that do and don't motivate our clients and our population to be doing and making the choices that they make. Good information will probably change that particular behavior and habit. And most parents, you would hope, would be appalled to learn that this well-intentioned good idea to help their babies get to sleep better is actually harming them in a really substantial way. So, interesting example. And then finally, I want to talk about helping address staff and managers and manage their moral distress. So, just name some sources of moral distress. Just shout out some sources of moral distress for you about the things that we've been talking about this morning. Anybody want to yell out some? What bothers you? Yeah. So you don't have time, so, and you feel like you can't do your job to manage both this child and parent, or help them and help all the others that is on your caseload for today. Other sources of moral distress. No money, yeah. That's a big one, yes. So you've done all this work to convince parents to come in on schedule. Parents phone up your clinic, sorry, you can't get in. And the parent comes into you and says, you told me that I had to be here at 2, 4, and 6 months. I'm not sure in all provinces if that's the schedule. It is in Alberta. But now you're telling me I can't get in for 3 weeks. So then what do you have to say? Well, it doesn't really matter that you got in 2, 4, and 6 months. Right? So that's a source of moral distress to you. How do you actually portray that, do the job you're trying to do, and still give accurate information and protect your children? Any other? I had a long list, but I didn't write it on the board because I was going to make you do it all. Remember that there's a difference between moral stress, which is positive and enabling. It makes you think differently. It makes you get in together with your groups, with your colleagues, with those that you serve, and ask these tough questions and answer them. It's potentially transformative. And the difference between that and moral distress, which is disabling. And we have way too much moral distress in our healthcare environments. So considering the best available evidence, appropriate economics considerations, and attention to good process always, proper ethics analysis, the opportunity for inclusive discussions with all the players, diligence in the review, and the evaluation of the features of your programs with all the players, will best reduce the risk of unaddressed moral distress. But you have to have the time, and so this is a bit of a plug. You need to get to, if you don't have access to ethics resources, you need to get those resources accessed. And all of you will have in your environments at least some access. You need to make sure that you advantage ethics opportunities for conversations, at least, in public health and in community health. Ethics is not about the high impact issues in hospitals only. It's just as much about home care and other places. So I give a shout out to one of my colleagues, Connie Mahoney, who many of you know, who's done a really phenomenal work with the public health ethics interest group of nurses and in other home care community areas to actually give people the time for that moral reflection. So once a month or once every couple of months, everybody gets together for a couple of hours and actually hashes out some of these issues and talks about them, because we're left as health providers in isolation, not being able to have conversations about that. One of my favorite pictures on a trip I took, it was a cruise expedition to the north from Greenland to the Northwest Passage, where I saw lots of really interesting public health issues amongst the Nunavut and the Inuit people, which I will not talk about. And I'm done. Thanks.